to today's webinar organized by ISAM. Uh, I'm Nivedita Shetty, an associate scientist at Genentech and also co-chair for the New Device and Networking Group at ISAM, and I'll be co-facilitating this webinar along with my colleague and ISAM board member Stefan here today. Uh, just like to highlight that our webinar today is sponsored by Actermo Medical. It's an unrestricted educational grant, and we are really grateful for this sponsorship. Before I introduce our speaker for today, just a quick few housekeeping tips. So all participants will be muted during the presentation. So just request everyone to hold on to your questions. Feel free to type in the chat box, but I'll be only reading them out towards the end of the webinar, where we'll have a quick 10 to 15 minutes for question and answers. And I think the slides will be available on the ISAM website post this webinar. So stay tuned for that. Okay, without further ado, I'd like to introduce our speaker for today, Dr. Gerhard Scheuch. He is the co-founder of GS Bioinhalation, which is a pulmonary consulting company. Back in 1988, he founded Actevero, which is a respiratory area specialty pharma company. He served as the CEO and president of Actevera for about 16 years before it got acquired by Vectura in 2014. He was also the co-founder for Ventalion, which is a drug development company for an inhaled treatment against severe influenza. He received his PhD in biophysics from the Johann Wolfgang Goethe University in Frankfurt back in 1992. His thesis was on dispersion, deposition, and clearance of aerosol particles in human airway. His research interests include deposition and distribution of inhaled aerosols in the area of human respiratory tract, mucociliary clearance mechanisms, and drug delivery to the human lung to treat pulmonary diseases. He has published over 150 scientific articles on aerosol and lung research. He's also a member of the expert panel of the European Medical Agency and more recently was involved in developing the guidelines on oral inhaled products. From 1999 until 2013, he was a member of ISAM, a board member at ISAM, and he also served as a president from 2009 to 2011. We are really pleased to have him back with us here today, and he's offered to give a wonderful presentation on this very burning topic with the new 2019 coronavirus. And we have a great turnout of participants. I'm sure everyone's waiting to listen to you. So with this, Dr. Scheuch, I would like to turn it over to you.
Thank you very much, everybody. I hope you can hear me. Okay.
Yes, perfect.
Yeah. Okay. So I didn't know that I did so much in the last years. What you all mentioned now. Thank you very much, Nivedita. Good morning to the West. Good afternoon here in Europe, and good evening in the East. Let me first explain what I have meant with breathing is enough. It should not be understood as breathing is the only mechanism that transmits SARS-CoV-2 viruses, but it means that someone must not necessarily need to cough, to sneeze, or to speak, or to sing to transmit the virus. And I think this virus will keep us busy for the next months and hopefully not years. Let me first start with the definition of the aerosol, because I read a lot about aerosols in the last weeks, and this was also the motivation of my talk today. I give you a small history of exhaled aerosols, SARS-CoV-2 as an aerosol, question mark, and the consequences out of this. I will start with some general remarks. I know that all of you, I hope that all of you knows what an aerosol is, but the definition of aerosol seems not to be clear to everybody in the world. When I read some articles about aerosols in the last weeks, if they are published in high-level journals or the WHO or the German Robert Koch Institute. An aerosol, as we define it, And I think that is the definition of an aerosol, is a suspension, a mixture of fine solid droplets or liquids in air or another gas. It's a suspension, it's a mixture. Even in high-level journals, I read something that was, in my opinion, totally wrong, because they mix aerosol particles and aerosols. So aerosol particles are the fine solid particles or liquid droplets. So sometimes we also use aerosol as a term for the particles. The aerosol particle must stay in the gas for more than a few seconds. That's the definition. Otherwise, we are not talking about aerosols anymore. So, for example, fog is an aerosol, rain is not an aerosol. But there is no upper size limit. And I read now in many articles, particles larger than 5 micrometers are called droplets, and smaller particles are called droplet nuclei, whatever that means. And this is an aerosol. So this is totally wrong. So a particle, a water droplet of 10 micrometer needs 6 minutes to fall to the ground from 1 meter high. So it is definitely an aerosol particle. There is no 5 micrometer limit. And a droplet nuclei is not an aerosol. It might be an aerosol particle, but it is not an aerosol. So when I spoke with the German president of the German Robert Koch Institute, because they had also a totally wrong definition on their page, he said, yeah, we copied this from the WHO page. Wow. They not had a false definition there. They had a statement there until late April. The statement was, the transmission of SARS-CoV-2 as an aerosol is unlikely. Today, the statement has changed to, the transmission of SARS-CoV-2 via contact of contaminated surfaces cannot be excluded. Little change in their definition. Today, they have a long statement about the aerosol transmission on their page with several examples and about aerosol transmission. And even in Wikipedia, when you look to the definition of aerosol in Wikipedia, they have different definitions on the English and the German side. On the English page, it is stated, the liquid or solid particles have diameters typically less than 1 micrometer. Larger particles with a significant settling speed make the mixture a suspension, but the distinction is not clear-cut. I don't know what that means. I have no idea. So, but that is on the Wikipedia. So I would ask you all in the audience to raise your voice always when you see such a silly definition and a wrong definition. So we as aerosol experts, we shall raise our voices and say, hey, stop. That what you're talking about is not an aerosol. But now finally I want to start my lecture. So there, as I said, there is no 5 micrometer limit. When you look at the deposition in the respiratory tract, and I plot deposition versus particle size, particles 1 nanometer large and particle 100 micrometer big, this is the deposition function of the total respiratory tract if an aerosol particle enters your mouth or nose. This is the intrathoracic deposition. That means this is the lung deposition. Here is 5 micrometer. And you clearly see that a lot of larger particles can enter the human lung. And they can enter the nose and the mouth and the throat. So there is no limit of 5 micrometer. No, it's you see that even 5 micrometer is almost the maximum of the deposition in the lung. So I don't understand where this 5 micrometer comes from. So back to 1986. I worked in a research laboratory in Frankfurt in Germany, and we did a lot of investigation on particle size deposition in the human lung with different flow rates and volumes and so on. And we used a very sensitive, strong laser photometer. And because we want to measure very tiny particles. And we measured during quite normal breathing of healthy volunteers a generation of aerosol particles from the lungs. And we published this in 1988 at the ISAM Congress in Rochester. Joseph Gebhardt, my colleague from Frankfurt, had a poster there. And what we found out with many experiments we performed was, number one, where is my, there. Number one, the origin of these particles was the deep lung. So we couldn't find particles at the beginning of a breath from the mouth and throat. So these particles, the origin was the deep lung. On average, these particles were about 0.4, 0.5 micrometer. We found some bigger particles up to 2 micrometer. We found smaller particles. A breath hold could reduce the number of these exhaled particles significantly, and the flow rate did not change the concentration. With an RV breathing maneuver, that means a breathing first to residual volume, very deep exhalation and following inhalation, the concentration of these particles increased significantly. We found huge differences between subjects. There were subjects, they had only one or few particles per liter of exhaled air, and there were other subjects where we found thousands of particles per liter of exhaled air. There was one examination we had with one of our subjects. He had on one day a huge number of exhaled particles, and we followed him the whole day, and it didn't go down. The other day, it turned out that he got sick. He had an airway infection. After 2 or 3 weeks after recovery, his concentration went down again, and during this infection, he had several orders of magnitude higher expiration of particles. So our conclusions at that time was, number one, the particles were not generated by shear forces. These particles are generated during inhalation, and it might be that the reopening of collapsed small airways was responsible for this finding. I listened to a webinar two or 3 weeks ago from a company, Pexa, in Sweden, and they had this very nice animation, and I asked them to borrow me this animation I can show you today. This demonstrates how these particles are generated. So during expiration, some of our very small airways collapse, and then during the next inhalation, these airways reopen again, and then small droplets are formed, which are expired during the next breath. So during inspiration, these particles are formed, and then during the next breath, they are expired. Pexa has now produced an instrument where you can analyze these aerosol particles that are generated in the small airways, and they can not only measure these particles, but they can identify the molecular contents in these particles. So our next conclusion was that an increased production of surfactant or mucus could increase this exhaled respiratory droplets. Meanwhile, this research was confirmed by many other research groups. I have published a few of them here. Katharina Schwarz and Jens Hohlfeld from Hanover, Johnson and Moravska, as well as a group of Anna-Karin Olin from Gothenburg, have studied these exhaled particles production in the human lung, and they confirmed these findings. Particles are small, particles are produced in small airways, particles are produced during inspiration, and so on. The variability of these exhaled particles is huge. Here's an experiment from the group in Sweden, from Anna-Karin Olin. You see that different breathing maneuvers change the number of expired particles a lot. Here, these are RV maneuvers that I described before. You see that generates a huge number of these particles. These numbers are still small compared to what is in the air around us, because these are only 15 particles per cubic centimeter, or 15,000 particles per liter of expired air. There's also intra-subject variability, not only inter-subject variability, that is shown here. Also, this is a picture from the group from Anna-Karin Olin. And they measure different substances in these expired particles. In 2004, I did a study together with my colleague David Edwards from Boston. What we did was we asked our subjects to inhale isotonic saline before we measured these expired aerosol particles, and we could reduce the number of expired particles significantly. I think it was by about 75% we could reduce the number of exhaled particles when we asked our subjects to inhale an isotonic saline solution before the experiment. So, and that is also the reason that I don't believe what is now published in some publications, in some journals, that a nebulized therapy would generate more viruses. I don't believe this. We should not mix medical aerosols and aerosols generated by the human lung. I think it's vice versa. If you inhale with a nebulizer an isotonic saline solution, you would reduce the number of exhaled particles and therefore would reduce the number of expired viruses. What we did also in this experiment, we asked our subjects to inhale surfactant. And what happened then was we increased the number of exhaled bioaerosols by a factor of 5. So this was again a hint that surfactant in the human deep lung are generating these particles, and this is also now, we now know that it is by this reopening of the airways. The question is now, okay, we understand during normal tidal breathing, we are generating aerosol particles. But do these exhaled particles contain viruses? That's the question. When David Edwards went back to Boston, he motivated his group around Patricia Fabian and colleagues to study this. And they really showed in the first study, which was published in 2008, Patricia Fabian first showed that in a limited number of influenza patients, they found influenza viruses. And they found them in the very small particle size range. In the size range that we also found in our experiments already in the late 80s, smaller than about 1 micrometer. Donald Milton and colleagues measured virus RNA in 37 influenza patients. And this is a very, very interesting publication. In the larger size fraction, which are generated by cough, by speaking, and so on, they found in 16 out of 37 patients virus RNA. In the small size fraction, which is mainly generated by normal breathing, they found in 34 out of 37 patients virus RNA. That gives the first hint that the smaller particles might contain more viruses than larger particles, which is not totally clear and it's not really significant, but there was a trend. They also measured the culturability of these viruses. Are these viruses alive, which are generated? And this was the result. And they not only measured the culturability, they measured also whether or not a mask, a medical mask, could keep away these aerosols, these particles from the environment. So with the coarse fraction, very significant effect. You see the mask, when wearing a mask, there was almost no coarse particles it could escape. But for the small particles here, you see that no mask and mask, yes, there was a significant reduction, but still there were a lot of virus containing particles escaping into the environment. And the culturability was significantly higher in the small particle fraction than in the large particle fraction. The median number for particles larger than 5 micrometer was 0 copies, and for particles smaller than 5 micrometer, 110 copies. So the statement in this paper was fine particles contain almost 9 times more viral copies than did coarse particles. So again, a clear hint, these particles which are generated in the small airways, which escape during expiration, during normal breathing, they contain viruses, influenza viruses. David Lindsley published data in 2016 also that he found viable influenza A viruses in air samples. He investigated 53 subjects with influenza A. In 53%, he found viruses in particles generated by cough, and in 43% in particles generated by breathing only. His conclusion was, viable influenza A virus was detected more often in cough aerosol particles than in exhalation particles. But the difference was not large. Because the individuals breathe much more often than they cough, these results suggest that breathing may generate more airborne infectious material than coughing over time. Our results are also consistent with the theory that much of the aerosol-containing viable influenza originates in the deep lungs. What do we know about SARS-CoV-2? We know influenza viruses, it's pretty sure that they can be expired, that they can be exhaled by normal breathing. But what do we know about SARS-CoV-2? Number one, we know that SARS-CoV-2 adapt to an ACE2 receptor when entering the host cells. We know that viruses cannot survive without our host cells. They have to replicate in our cells, and one of our and they need the ACE2 receptor to adapt to the cell. And there are ACE2 receptors in the deep lung. There are no or very little ACE2 receptors in the bronchial airways. There are also ACE2 receptors in the nose, in the human nose. Small amount, but also they are there. But there are ACE2 receptors in the deep lung, and these and the ACE2 receptors are in alveolar type 2 cells, which also are responsible for generating the surfactant. So which makes sense from the virus that want to escape out of the lung again. The first publication I found, what makes me thinking that aerosol plays a role in the transmission of the SARS-CoV-2 virus was a paper which has now been retracted. But when the paper came out, I saw these numbers and I thought, hey, this looks as if the SARS-CoV-2 is also in the small exhaled aerosol particles. Bayer and co-workers, as a group from South Korea, found in 4 patients with COVID-19 that virus particles could be detected in petri dishes in front of the patients, despite the fact that they were wearing face masks. And they published that no viruses could be detected on the inner surface, but on the outer surface of the masks. And that was for me a hint, hey, if this is true, then these particles must be very small, so that they penetrate through the face mask and deposit outside of the face mask. And that was one of the first indications for me that SARS-CoV-2 could be transmitted via aerosol. And this publication came out in a time where the WHO and the Robert Koch Institute still said aerosol transmission of SARS-CoV-2 is very unlikely. On April 2, there was a paper published about an outbreak in a restaurant in Guangzhou in China, and they had a very nice picture in this presentation that I show you here. The viruses were infecting people which were sitting on 3 tables in this restaurant, and when they simulated the air conditioning and the airstream in this restaurant, they found that the air was moving in this direction into this restaurant. So there were a lot of other people in this restaurant which were not infected by SARS-CoV-2, but 7 people which were sitting here on these 3 tables were infected by SARS-CoV-2. And it's very likely that this transmission happened via an aerosol cloud. On March 19, Van Dormaelen and co-workers showed that SARS-CoV-2 viruses could survive over several hours in an aerosol when they sprayed it into a closed, non-ventilated room. Qiang and co-workers published on April 7 data about more than 7,000 infections. And they had a statement in the presentation and that said the corona COVID-19 infection is an indoor phenomenon. They found only 1 single transmission outside of a room. April 10, Lydia Morawska and Junji Kao had a presentation, and it was a very clear statement. Hey, world, airborne transmission of SARS-CoV-2, we should face the reality. We should not only wash our hands and clean the table and clean everything. There can be an airborne transmission. On April 27, Liu and colleagues took aerosol samples in a Wuhan hospital. And they found in several of these samples SARS-CoV-2 viruses. And they had really viral copies. They were active, not only RNA. In a protective apparel room, removing room, they found most of the viruses in this particle fraction between 0.25 and 0.5 micrometer, which can well be that the air was contaminated with these viruses by patients in this hospital. Also very interesting study, which could be an aerosol contamination, was an attack rate following exposure at a choir practice in Washington. There was only 1 index patient, and he visited 2 choir practices, and after a few days, 53 out of 67 singers were had an infection, which is also a very clear or not a clear, but it's a hint that this transmission might have happened via aerosols. You know, this is singing, so this aerosols cannot only be generated in the deep lung, but also in the upper airways. Santabia and colleagues from the University of Nebraska took also air samples in hospitals and found SARS-CoV-2 viruses even in samples in the hallway outside of the patient room. They also found positive air samples in the absence of cough of the patients when they took the air samples near these patients. And this is from July 8, I found a paper now, transmission of SARS-CoV-2 virus as aerosols, not only in human. Here there was an experiment with ferrets in 2 different cages with 10 centimeters difference between the cages. And what they found was that SARS-CoV-2 was transmitted via the air to 3 out of 4 recipient ferrets. So this study provides experimental evidence of robust transmission of SARS-CoV-2 via the air. I don't know whether or not ferrets are singing, talking, but they are breathing. So for me, the question, transmission of SARS-CoV-2 as an aerosol, I would definitely say yes. There is sufficient evidence to believe that the aerosol route is an important transmission factor in this pandemic. My feeling is that there are 2 ports of entry for this SARS-CoV-2. One is the nose, where we have this ACE2 receptors. And maybe if you are infected via the nose only, you might have a mild disease, a milder form of disease. The other region, the alveolar region, where we have this SARS-CoV, this ACE2 receptors and the alveolar type 2 cells, if you have an infection there, with these tiny aerosol particles, I think the disease can be severe. That was an interesting statement that we discussed in our German Lung Society small group where we have some discussions between us. Aerosol particles can be generated by breathing, speaking, singing, coughing, sneezing. I would say a distinction between droplets and aerosol is not needed. If particles in the air are inhaled, it's an aerosol infection. So if the particles are like bullets, big, huge droplets, if they are in the millimeter size range, I don't think that you can really inhale these particles. Then it should be a contact contamination. Now the question, if we have this understanding that aerosol is a very important route of transmission, what can we do? What can we do to protect ourselves? Number one, limit number of contacts, social distancing. That was one of the first measures that was taken in Germany. No parties, no choir practices, closed restaurants, closed schools, no bigger events indoors. And in Germany, that was, I think, the most important measure to stop the very high transmission rate. Face masks. I think, yes, face masks are needed. They are not 100% efficient, but they can reduce the number of at least to reduce the number of particles which are exhaled. I think that air filtration can be one of the measures. We can reduce the concentration of exhaled particles also maybe by inhalation of isotonic saline. If we have patients in the hospital setting, we can ask them to inhale isotonic saline, and therefore we can reduce the number of expelled particles. And there are other measures. I will speak a little bit about masks. There are pros and cons. I think at the moment there are more pros than cons. There's a meta-analysis of randomized controlled trials, and they clearly showed that clinical respiratory illness, the risk is reduced by over 40%, and the risk for influenza-like illness is reduced by over 60%. So I think that is, in this meta-analysis, we can have a clear statement, and that is also in this paper. Our analysis confirms the effectiveness of medical masks and respirators against SARS. Disposable cotton or paper masks are not recommended. That was the statement in this paper. Renny Zhang and colleagues found that wearing face masks had an effect on the distribution of SARS-CoV-2 in pandemic. So their statement was, we conclude that wearing of face masks in the public corresponds to a most effective mean to prevent interhuman transmission in conjunction with simultaneous social distancing, quarantine, and contact tracing represents the most likely fighting opportunity to stop COVID-19. That's 9 months missing. There are a face mask con. McIntyre tested the wearing of surgical masks and no mask in a controlled study, and the report was there was no difference. They found in their study no difference between wearing a mask, face mask, surgical mask. It's a small study, but their conclusion was that in household use of face masks is associated with low adherence, and maybe that is a reason of this effect, and therefore it is ineffective. Face mask con, also a study from McIntyre from Australia. They investigated 1,600 healthcare workers, randomized them in 3 groups, wearing no mask, wearing a cloth mask, and wearing surgical mask. Very clear, the outcome was significant reduction of clinical respiratory illnesses, influenza-like illnesses, and laboratory-confirmed viruses when wearing a surgical mask, but negative effect on all 3 of these illnesses. So surgical mask, yes, face mask, normal cloth mask, yeah, better not. So the conclusion for me is the use of surgical face masks can be strongly recommended. In many studies, we showed that the use of cloth masks is questionable. There was a statement in the paper from Chuktai and others. The filtration effectiveness of cloth masks is generally lower than that of medical masks or respirators. However, cloth masks may provide some protection if well designed and used correctly. Until a cloth mask design is proven to be equally effective as medical or an N95 mask, wearing cloth masks should not be mandated for healthcare workers. In community settings, however, cloth masks may be used to prevent community spread of infections by sick or asymptomatically infected persons, and the public should be educated about their correct use. I think that is a very good and a statement of what I can understand. Air filtration. That might also be a possibility to use room air filters. There are HEPA filters which are very efficient. I made a calculation. When you have an infected person in a room and this person exhales 100 virus copies per liter of exhaled air, breathing maneuver 15 breaths per minute, 1 liter room volume for these square meters, cubic meters. The time 2 hours. Half time of viruses in air is about 2 hours. The result would be 132,000 virus copies after 2 hours. That means 3.3 virus copies per liter. And in 10 minutes, when another person comes into the room, the person will inhale 500 virus copies. This can be enough to cause an infection. So this is when you have the particles in the room without air filtration. When you have an air filter that removes 50% of the aerosol within 12 minutes, then this curve looks like this. And if you have an air filter in the room that reduces the number of particles within 5 minutes, then this is the curve. When you have air filtration in the room, we have all the same. The result is then only 20,000 virus copies. That means 0.5 copies per liter of air. And then a person that enters the room will only inhale 75 virus copies. Yeah, so you can at least reduce the number of viruses in the room when you use air filtration in a room. And this is used now in airplanes and in other transport systems. And also in Germany, they start now using air filters in restaurants. The most efficient filtration is opening the window. Yeah. When you open the window, you clean the air in your room within a few minutes. If this is not feasible, air filtration might be an alternative. And these HEPA filters are really very good. They can reduce the virus burden by a factor of 520. Virus inactivation by UV light. There are some publications coming out, one from Buonono and colleagues inactivates coronaviruses with UV light 222 nanometers, which is not harmful for the human skin, and they could 99.9% reduction of virus copies in 25 minutes. Michael Scheuch and co-workers found that simulated sunlight rapidly inactivates SARS-CoV-2 in aerosols, and Hiroko Inagaki and colleagues used deep UV light, that is a 280 nanometer light, and it resulted in 99.9% inactivation of SARS-CoV-2 in 1 minute. So there are possibilities to inactivate the virus with other measures than only face mask and cleaning of the room air. In conclusion, I think it's very plausible that SARS-CoV-2 will be transmitted via aerosol. I think the hints, the evidence from the literature is relatively convincing. Is it the most important transmission? I don't know. I think so, but I don't know. Aerosol transmission, if we define it as a transmission of aerosols which are deposited in the nose and in the lungs, I think it is the important transmission factor. Wearing of face masks seems a possible measure to reduce transmission. There are other measures like HEPA filters to reduce infection in closed indoor rooms. We know that the problematic of transmission of SARS-CoV-2 is an indoor phenomenon. So going outside reduce the transmission by factors. And so in indoor rooms, we have other possibilities to reduce the infectivity. UV light might also be an alternative to reduce SARS-CoV-2 and reduce the viral burden, at least if other measures are not possible. Thank you very much for your attention. Dankeschön. And we can have, I think we have time now for questions.
Thank you, Gerhard. That was great, very informative. So we already have a question. So I will probably read that out. And okay, so this question is from Professor Barbara, and she says, great talk. And her question is, you mentioned to reduce the exhaled virus load by inhalation of saline. However, this will increase the virus load for the patient. Is this not, okay. Yeah, sorry, I'm missing. Is this not bigger? Sorry, it's getting cut for me. Is this not a bigger risk for
So,
the
so
patient as viruses are not cleared via
for the
exhalation?
patient. I don't think that the exhaled route is the main route of getting rid of this viruses. I think that other that our body has other measures to reduce virus load in the body itself. So I think that the viruses which are exhaled are only a very small proportion of the viruses which are really in the body. But I'm not a virologist, so maybe we can find a virologist to help us answer this question. But I doubt that by exhaling of a few particles that the amount of viruses in the lung will increase significantly for the patient, because I don't think that the exhalation route is the route that reduces the number of viruses in the body.
Okay. Great. Stefan has raised his hand. Stefan, do you want to go ahead and ask your question?
Yeah, thank you very much for the great presentation. I have a technical question to see how can we go further in investigating the question, and in particular to have a quantitative analysis, because I think it's from all you showed, it's clear on a qualitative point of view that it is possible to have airborne transmission, aerosol transmission. It is possible, but the question is really, as you mentioned, is it quantitatively important compared to contact transmission? And as people do well one thing, if they wear masks, they won't wash their hands. Basically, it would be best to do both, of course, but I mean, that is what happens even in the hospital. I mean, you do well one thing, and if it's not predominant on a quantitative point of view, maybe it's useless. And how could we investigate that? It seems very difficult to me how to design experiments to quantify those ways of transmission.
Absolutely, you are absolutely right. It's very difficult. I try to get information on how many viruses are needed to start an infection. That is not even known in influenza. I screened all the papers I could get on this, but I found a few papers that says you need about 300 to 3,000 inhaled influenza viruses to start with an infection. But 300 to 3,000, wow, it's a broad range. Yeah? So, and in SARS-CoV-2, no one knows. Yeah, are there 100? Are there 1,000? Do you need 10,000 viruses? We simply don't know. The other question on contamination infection. I don't believe, and now the Robert Koch Institute in Germany, they also said the infectivity by contaminated surfaces is very unlikely, because what are you doing with your hands? Yeah, you have the ACE2 receptors in the nose, and you have the ACE2 receptors in the deep lung. That's where the viruses have to adapt and have to replicate. How would you get them if you have them on your hand? How would you get these particles, these viruses into the deep lung? Sucking on your hand, put your fingers into the nose, yes, might be, but this is not a very likely transmission route, I think. So for me, I think it's more this coughing, sneezing, breathing, singing, that causes infection. This indoor phenomenon also shows, yes, we are sitting in a room. The room is not very well ventilated. When you have an infected person in the room, you have very quickly, you have hundreds of viruses in the air, and then you can inhale them and can be infected. How to quantify this? Maybe there's a possibility with these ferret experiments that we can get something out of this. There seems to be transmission in between these cages in ferrets. I don't think that you can do experiments in human, to put human into a box where you have 1,000 viruses and then hope that you get an infection. I don't think that this is that this is doable. Yeah, that would be the experiment you can do, but it's I think it's very unlikely that you get permission to do such an experiment. So it's I also thought about this question. It's very difficult to answer this question. How many viruses? What is a quantity? How can we quantify? How can we quantify it? How can we get out what is the really root of infection? Where are the most of the viruses? I think measuring air samples is an idea that is done now in a few hospitals, but it's a very good question, but I'm not I cannot answer that.
Okay, I'll move.
But it's very important to know.
Yes, that's true. We have a lot of questions, so I'll just move forward with the next one. What fraction of publication measured culturable viruses, not just RNA copies?
I found 2 papers so far. I don't know if they measured culturability. Most of the measurements are just RNA measurements.
The next question is from Teresa, and she was inquiring if there is additional information about how oxygen devices may participate in dispersing these particles into the room via gas flow or leak around oxygen devices.
You mean oxygen therapy? I don't think that oxygen therapy generates more viruses into the air than normal breathing. Because it's not shear flow that makes this virus this particles. It's more than if you have oxygen in the nose. It's maybe sneezing, but I cannot think about real physical factors that can cause more viruses be generated by oxygen therapy.
All right. Next question is from Marina, and her question is there any information of adverse effects on the brain with nasal exposure? And the second part of her question is deposition changes in patients with airway disease.
With airway disease, deposition not change with airway disease. That was a finding we did with medical aerosols. It was also a little bit surprising for us. That the deposition of particles does not change so much with airway diseases, especially if the aerosol particles are so small that they can get very deep in the lung. They get deep in the lung if you have COPD or if you have an asthma. They will get into the deep lung. It can only be that COPD patients with restricted airways will have a less deposition in the deep lung, but I think that this is not really significant. What was the first?
First part was: is there any information about adverse effects on the brain with nasal exposure?
No, I don't know. I have no idea.
The next question is from Connor, and he says, along the lines of viral exposure, can you comment on the severity of illness with the amount of virus to which one is initially exposed?
That is a very good question, and I think I discussed this question also with Professor Köhler and Professor Fossa in Germany, the pneumologists, and they think that this can well happen. So if you get a very high load of initial exposure to viruses, your immune system has no time to react, and then the disease can be very severe. If you have an if you have an attack in the nose, so that's our idea now, then your immune system has more time to deal with this infection, and the disease might be milder. It's a hypothesis. It's not that is not hard science, but it's a hypothesis that especially when you get a very high dose at the beginning, that the disease can be more severe.
I missed a question by Roy, and this was asked again by Jody, so I'll just read this question here. Any thoughts on the risk of transmission with nebulized drugs?
No, I can see no effect that would cause more viruses getting out of the lung when you give a patient a inhaled therapy. I think it's vice versa with the experiments from David and me in 2004. Especially with an isotonic saline solution, we found significant reduction of expired particles. So I don't see any risk to give a patient an inhaled therapy, neither with nebulizers nor with metered dose inhalers. There might be a little more risk with a dry powder inhaler, but I will not. I don't think, because it generates, maybe it generates a little bit more cough. But normal dry powder inhalers have so less particles that it should not be significant.
All right. Great. We have a question by Bill Bennett, okay, I'll read it out, and I've also unmuted him so he can read out the, add on if I'm not clear about the question. So his question is dose question mark, threshold question mark, so dose per time. Okay, actually, I think I just let him read out the question. Bill, you're unmuted, so would you like to read the question or ask your question? Okay. Okay, probably because of the short of time, I'll probably move to the next question. Sorry about this. The next question is by Chris. When we looked at RSV aerosol transmission, the virus was still present in cubicles. 2 hours later, they left the cubicle and also could infect ciliated epithelium. What is the time between patients for SARS-CoV-2? It's just a guess at present.
I have no idea. I must say, number one, but number two is, I don't think that there is an infection in ciliated airways, because there are no ACE2 receptors. So I doubt that there's a similarity between RSV and SARS-CoV-2. But that's not I have no experience with this with RSV infection.
All right. We have a lot of questions and about 2 minutes to go. So probably we can take one last question, and maybe those who still have some more questions can reach out to you at a later point or something, if that's okay with you.
But they can even contact me, and I will try to answer
Great,
the
yeah.
question.
So I'll just maybe one more question by Tim. If secretions go from the patient to the nebulizer reservoir and get nebulized, you can transmit infection. Okay, I think this was more a suggestion, maybe.
But this is, but how will the secretion get into the nebulizer? I think yes, there can be something, but I would doubt that this is a really a huge problem. There are much different other problems. I think when a patient is exhaling the whole day into his room, the number of particles which are expired during a 10-minute or 5-minute inhalation maneuver is negligible. This will not increase the number so much.
All right, probably just one last question.
And I think it can be easily tested.
Right, maybe I'll just take one last question.
Yeah. Right.
What about infection starting in the nose where ACE2 is higher than in the deep lung, followed by aspiration into the lungs? This would provide a benefit of even cloth mask to help keep people from inoculating themselves by rubbing their nose while in public. Cloth mask may also,
Yeah.
yeah.
This can happen. Yeah, if you have an infection in the nose and you bring this into the deep lung, I think this is one of the route how the aerosol how the viruses can get deep in the lung, not only directly by the aerosol but also by the secondary aerosols which are caused during inspiration through the nose. I think that can really happen. What was the question about the face mask then?
It says that this would provide a benefit of even cloth masks to help keep people from inoculating themselves by rubbing their nose while in public. So cloth masks may also prevent inhalation of large particles that would deposit in the nose. So I think it's more of a, yeah. So yes,
Yes,
is dose the key
definitely yes.
to limit time of exposure?
Yeah, yeah.
So yeah, I think that was the last question that we could take, and we are running out of time. But I would just like to tell people that on 5th of August, we have another webinar coming up on the methods to nebulize in COVID patients, since we had a few questions around that. So uh, that would be interesting to dial in then. And I think we covered up a lot of questions, and this was great. And definitely a lot of folks were interested. Thank you so much, Gerard. Is there anything else you would want to add before we sign off?
No, thank you very much for your attention, and I think that was all what I want to say. And I hope that we can get a clear definition of aerosols into the world when we all raise our voices and
Yes.
not only sit there and say this is a wrong definition.
Yeah, I think your first
Thank you.
was plus side was very interesting, and yeah, we should point it out. Great, thank you, and this was really interesting. Thank you all for dialing in, and have a wonderful rest of your day.
Thank you.
Sorry, I had to rush through some of the questions.